So good morning, everyone. If people can take their seats, I think we're ready to get underway. My name is Peter Adamson. I'm a pediatric oncologist from the Children's Hospital of Philadelphia, and I want to welcome you to this morning's session. When we care for children with cancer, we routinely take measurements, and I think most everyone in this room would probably agree that we often take excessive measurements. Whether they're CBCs to tell us when children may require transfusions or when they may be at heightened risk for infection, whether it's renal function that may guide us as far as who may need a dose reduction of treatment, or when there are tests that tell us who may be at risk for future toxicity, such as echocardiograms throughout treatment. Pediatric oncology is filled with taking measurements that aim on helping us care for children with cancer, helping us lessen the toxicities of treatment, and manage the both short and long-term risks. Now, what we heard yesterday was that despite our extensive measurements, we all recognize we have a very incomplete picture. We don't know what children experience on a day-to-day, week-to-week, or month-to-month basis. And we don't know what children and families may need to effectively manage the remarkable stress that accompanies a diagnosis and then treatment. So today we're going to have 3 excellent talks on various aspects of how we can improve upon that. There are tools that exist and have existed for many years, and there are areas of research that are developing new tools, looking at support for psychosocial care, looking at patient-reported outcomes in children. So we'll have 2 talks with experts from the pediatric side of this equation, and also lessons that we can learn from the medical oncology side. Our talks are going to be from Pam Hinds, Ann Kazak, and Paul Jacobson, and I think it's going to be a very interesting session that will follow with the discussion. So why don't we get underway, and let me invite Pam for the first talk.
May I say good morning to every one of you. My name is Pam. I'm a nurse, and I'm a nurse researcher from Children's National Health System, and it is my great privilege to be with you this morning. I want to thank every one of you from our very diverse perspectives for being willing to consider how together we might actually make things better for children, adolescents, and young adults with cancer and their families. So I do want you to know that I have no conflicts of interest, but I have a huge amount of appreciation for 2 institutes at NIH who have funded the work that I'm about to share with you. And although I am the person who's with you and I hail from Washington, D.C., please may I share with you and honor the names of these individuals from 6 very different geographic sites in the United States who have helped to test the pediatric PROMIS measures. And may I also honor my colleagues in Shanghai, China, because they have translated our work with pediatric PROMIS measures with children with cancer now into Chinese and are testing these instruments in 3 hospitals in Shanghai. Today, during our time together, I'd like to share with you what I consider to be a pivotal moment in measurement for the child and adolescent experience in pediatric oncology, a very different measurement approach now underway. I'd also like to share with you a discovery that we have made in our analysis of the PROMIS symptom and function data, quite surprising for us. And then I'd like to present to you a rationale for why I believe all measurement in pediatric oncology really needs to be triadic. 3 units of analysis: the child voice, the parent voice, and the clinician voice. Today in my comments, I'm primarily going to be emphasizing the child report, Please forgive me for that because I do view the child as part of the family voice, and so I will be alluding to the family voice, but my data will today primarily be about the child voice because of the PROMIS measures having a longer history in pediatrics with child voice. Yesterday, we had quoted for us the definition of what is a patient-reported outcome, and the same definition applies for children. We're actually relying upon the FDA 2009 industry guidance paper, and that is, of course, that the PRO is any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. That definition does not in any way dispute the value of the parent voice or the clinician voice, but it legitimately adds the child voice. Why then would we be interested in the child voice in pediatric oncology? And I'd like to suggest to you that it's the voice that allows us to accurately then know symptoms, function, quality of life of children during and after cancer treatment. It's a crucial voice that without that voice, we cannot know the full impact of our protocol-driven therapies, and we cannot know the full impact of our nursing, medical, and psychosocial care. We also have early evidence indicating that when we invite the child voice, parents report pleasure, that the child's voice is so respected, and they report having a more trusting relationship with the clinical care team. Certainly in the last 15 to 22 years, we have a very interesting history of seeking the child voice, and I'd like to highlight a few of the aspects of that recent history before I move into the more current move with the PROMIS measurement system. So first of all, we have indeed demonstrated the feasibility of soliciting the child voice during cancer treatment, and the child voice related to symptoms, function, and quality of life. So we know that the child is willing to report from the moment of diagnosis forward to cure, or from diagnosis to end of life. We also know that for the most part, parents are willing for their child to report when parents understand the importance of the child voice and how that voice will be used. We know that in pediatric oncology, which is really protocol-driven, occasionally child-reported measures are embedded in those clinical trials. We know now from our documentation that when they are embedded, the parent and child participation rates are higher. When they are not embedded, parents and children will say, oh, another study. They don't see it as a companion study for the parent and patient reported outcome measures. They see it as yet another consent process. When the measures are embedded, we have an easier time of linking child report with traditional endpoints in pediatric oncology clinical trials. What we do know from our history in pediatric oncology is that only rarely are we linking child voice with actual care outcomes and endpoints. And even more rarely do we measure the child voice at end of life. In the last 15 to 22 years, what we also know is that a lot of our child voice measures have been cancer-specific. They were either developed specifically for children and adolescents in cancer care, or they were validated in those populations. And on this slide are examples of such measures. Now may I take you into what I consider a pivotal change in measurement in pediatric oncology, and that would be the PROMIS initiative, which is an NIH Common Fund initiative. And it's patient-reported outcomes measurement information system, and it is dramatically different from our previous measurement approaches in pediatric oncology. Those past attempts at measurement, well done, had been primarily dependent upon classic psychometric theory. In contrast, PROMIS is very dependent and guided by human development theory and measurement theory. And the primary measurement theory is item response theory. PROMIS then has what's called item banks, and the item banks have been developed from two primary sources. One being qualitative or focus groups with well children and children who have chronic and acute illnesses. Chronic illnesses such as sickle cell, rheumatology, asthma, and cancer. These item banks can be up to several dozen items that have been tested then to comparably contribute to measuring the underlying construct. This means that from those item banks, we, as researchers, can extract 4, 6, and 8 items to measure the construct of interest. I would personally, from experience, recommend 6 to 8 items minimum and not 4 for purposes of internal consistency measurement. The second source of guiding us with creating the PROMIS measures was the literature, looking at already tested pediatric items that were impressive in their previous testing. What's really exciting about these measures is that they are publicly available to all to use without fees at this point in time, and that's because they were generated by our taxes. Quite exciting for us is that the age specificity for the PROMIS measures is broad. So the previous list that I shared with you had age-specific categories that range from 3 to 5 per measure. So that sounds very exciting in terms of child development, but in fact, for measurement purposes, unless there is confirmed conceptual need for so many categories, it results then in great difficulty of getting sufficient samples in pediatric oncology to trust the number of reports that we have within each one of those age categories. So PROMIS for pediatrics has one age category at this time, which is 8 to 17, and our most recent study, not fully published, 8 to 18. Please notice the limitation, which is we do not have PROMIS pediatric measures validated for children younger than 8, so certainly that's a concern for us. These, these are the validated PROMIS pediatric measures to this point in time. Please notice that they are divided into emotional functioning and distress, physical functioning, and then pain, interference, fatigue, peer relationships, and asthma. The second column shares with us those pediatric PROMIS measures that are now in development and early testing, one of which is almost ready for wider scale testing. And these new measures are very exciting for us as they go after additional domains of family, symptom, and functioning. There are also parent measures that are in development and in early testing phases, so the PROMIS banks are expanding. I'd like to introduce you to 3 of our PROMIS studies in pediatric oncology and to walk you through early findings related to analysis and one of our surprises in analyzing our data. So if I may introduce you to study number 1, which we called PROMIS 1. It's a cross-sectional study which we did very quickly to look at feasibility, acceptability of these measures during acute care treatment for cancer and in survivorship. And we had more than 200 participants, fairly equitably divided between those patients in treatment and those patients in survivorship. PROMIS 2 is the second study. This was a longitudinal design. We wanted to find out, do the pediatric PROMIS measures sensitively capture change over time? We chose 3 data points in about a 30-day period representing a course of chemotherapy. So children and adolescents ages 8 to 18 who were on their 2nd to 6th course of chemotherapy were eligible to participate in this longitudinal study. This particular study also allowed us to do a legacy comparison between the new PROMIS measures and the previously established fatigue measures. More on that in just a moment. The third study was purposefully embedding the PROMIS pediatric measures in a phase 1 clinical trial and was quite purposefully done so we could demonstrate the acceptability, feasibility of asking a child whose cancer was incurable to report on symptoms and function at 2 different time points prior to knowing the status of response to the experimental agent. What I would share with you is that the first 2 rows are about enrollment, and you will notice refusal rates were exactly as we had predicted for a cross-sectional, a longitudinal, and a phase 1 clinical trial. We were very pleased by that level of participation. It rivals and exceeds previous reported levels of participation with more traditional pediatric oncology self-report measures. I would also, with much relief, point out to you the missingness rate. Very few of our measures were not completed, and very few of the items were not completed. In PROMIS 2, the longitudinal design, when we looked at missingness by item, there was no difference in missingness by gender, by age, by diagnosis. What was the reason then for missingness? The lack of ability to participate in the activity that was being measured. All good signs of feasibility and acceptability. In that first study, PROMIS 1, which was cross-sectional, we also wanted to establish known groups' validity. And so we theorized that our symptoms would be far worse in children who were on treatment than in those who were in survivorship, and that functioning reports would be far better for those in survivorship than those on treatment. And you'll notice that we found exactly what we had hypothesized. So good evidence of known groups' validity for the pediatric PROMIS measures, first time that it was established. Now I'd like to invite you into the analysis and what was quite surprising for us. So please consider that sample, which was almost half on treatment, almost half on survivorship. And so in analyzing the data, I very much wanted to know, by using latent profile analysis, is that in fact the profiling that we identified. I'd like to particularly honor Dr. Jishuan Wang, a wonderful colleague, statistician on our team, who is an expert with this particular approach. Notice that 2 groups did not evolve from that level of analysis. In fact, 4 profiles resulted. Certainly one that we had predicted was high symptoms, low functioning. That would be, we theorized, most of the children and adolescents in treatment. Inaccurate. Yes, the majority were that, but we had quite a few survivors who were also on that profile. Second major profile was low symptoms, high functioning. We theorized that would be primarily, if not all, survivors, and we were wrong again. It was a blend. And notice there are 2 middle profiles which have moderate symptoms and moderate functioning. So it's not so simple then as 2 theorized profiles. And it makes me wonder if our previous analyses of taking all voices at a single time point and analyzing them as one group has in fact been erroneous, because there are more than likely subgroups. What makes the subgroups important to us is if we can identify subgroups early in treatment, we will match our clinical care, whether it's supportive care or other forms of care, to do better by them. But would that subset continue? So now I take you into PROMIS 2, the longitudinal study, where we had those 3 data points spanning a course of chemotherapy. We hypothesized that the first data point, which was just before beginning the chemotherapy, would have low symptoms, good function, but 12 to 16 days later, when the nadir was hit, we would have high symptoms, bad function. And then at the end of the course, just before the next course of chemotherapy, we would have a return to low symptoms, good function. So LHL would have been what we were looking for in terms of symptoms, and we took our pain, depression, anxiety, and fatigue to look at these. And let me share with you that, again, the issue of subsets emerged. Notice there is a group of children and adolescents, almost 28% of the 96 who participated in this study started out with high symptoms, and the high symptoms continued all the way across. This is a subset of children and adolescents then who suffer greatly across all measurement points. We need to know, who are they? Notice that there's also almost 40% of children who start out with low symptoms, and they maintain that all the way across the measurement points. We need to know who they are as well. And then there's a middle group that also starts out low, but ultimately goes to high suffering. If we take the top pattern of all three suffering points, combine it with that middle pattern, 60% of children will reach high suffering across a course of chemotherapy. We're still analyzing the data, but there's one comorbidity that predicts who will be in the high group, and it's the question, how tired have you been in the previous 7 days? And those children who indicate that they have been very tired are consistently the children who are in the HHH, or the high suffering pattern. Part of what the patient-reported outcome work needs to happen in pediatric oncology is to anchor our patient measurements with clinical indicators that are widely trusted and interpretable. Is it possible that at some point in time, a patient-reported outcome could predict treatment response? I would suggest to you it's an unknown, but it's an area that we need to investigate. So part of anchoring our work then is to always have a theoretical framework around it, to link it to clinical indicators and more traditional endpoints. Yesterday we had a wonderful discussion about rare disease, number of participants needed to be able to test certain important research questions. And now, across all three of our PROMIS studies in pediatric oncology, we have sufficient responses to begin to test this model. I mentioned to you that I'm interested in 3 units of analysis, 3 voices: the clinician, the parent, and the child. We had good conversation yesterday about how they are not the same voices. Why would they be? They have 3 very different experiences that they bring to the discussion, but they are valid voices. And if we are to treat the family, we need all 3 voices. They are all credible, but they have different standards of comparison. The well-trained clinician will be comparing this child against all other children previously treated. The parent will be comparing this child from up to several weeks previously, and the child will be talking about very recent experiences. We need all 3 perspectives. What we know is that as we train parents and children to report, and we explain how important the reporting is to us, how we will honor it in treatment, that they take it much more seriously than just a research exercise. We have the training amongst us then to solicit the child voice, the parent voice, and then to use it clinically to work with the family. Unknown, but what I'd like us to explore is, are there family patterns of reporting? And if we knew the family pattern of reporting function, symptoms, quality of life, and we could provide that information to our clinicians, would that guide care in important ways? Perhaps there's even triadic patterns of lead clinician, family, and child. So in closing then, I'd like to emphasize these points. We know now that children can self-report during illness and in survivorship, and we know now that the PROMIS pediatric measures do sensitively capture change over time during treatment and in survivorship. We also know that parents and clinicians add very important perspectives to the ill child's treatment and end-of-life experiences. So those single units of analysis studies, child only, parent only, clinician only, are valuable, but they are insufficient to provide the kind of care that we all want to give. We need all three perspectives. So may I offer you several recommendations related to the child voice and particularly related to the PROMIS pediatric measures. First, we need to embed the child voice and the parent voice measures in all phases of clinical trials. There is no one clinical trial phase that we should favor over another, and we need to embed them at established points in survivorship. We need to explain to children and parents the importance of self-reporting and how we will respect and honor those. And then we need to study ourselves. Do we change our care when we have such information in our hands, or do we not? We need to be able to measure the child and parent voices consistently at meaningful points. We should not settle for the fact that we embed a child voice measure in a clinical trial. We should purposefully link it to trusted endpoints and make important clinical interpretations. Additionally, we need to assess reports for patterns at the level of child, parent, and family, and interpret those in a trustworthy manner to help guide care. And we need to develop validity assessments of the child, parent, family reports, and patterns, and link these to treatment outcomes. What I would also like to call your attention to is that just this week there's a new RFA out about the pediatric reported outcomes, and I hope every one of you will submit a grant in response to this invitation. Thank you all so very much.